I'm Chris Reback. We've all seen the headlines. 130 Americans die every day from opioid overdoses, while 2 million suffer from disorders related to prescription and non-prescription opioids. According to the Centers for Disease Control and Prevention, from 1999 to 2017, more than 700,000 people died from a drug overdose. And in 2017 alone, some 68% of the more than 70,000 drug overdose deaths involved an opioid. In fact, in 2017, the number of overdose deaths involving opioids was 6 times higher than in 1999. And while America's substance abuse crisis, from alcohol to opioids, has finally reached the public consciousness, the hard work, helping individuals and their families find proper treatment and ongoing support, is more important than ever. What should effective substance abuse treatment look like? Does the care end once a particular program ends, or does it need to be an ongoing relationship among the treatment center, patients, and their families? And what about the families? How can they find support while their loved ones seek treatment? Chris Mackintosh is the person to ask. Chris is CEO of Turning Point Centers, a collection of substance abuse treatment centers headquartered in Utah. Chris understands the challenges from all sides, as a provider who engages directly with individuals dealing with substance abuse, as a provider who engages directly with individuals dealing with substance abuse, as a family member who has seen the devastation that the abuse creates, and as a former substance abuser himself, someone who directly dealt with his own issues and knows firsthand the daily work required to stay sober and turn one's life around. But for anyone trying to deal with these challenges, either personally or with a family member, one question outweighs all others. How and where can I find help? In this conversation, Chris takes us inside Turning Point Centers and offers an important overview about our country's substance abuse epidemic and what evidence-based treatment looks like. Here's my conversation with Chris Mackintosh. Chris, thanks for joining me. I appreciate your time.
Chris, thank you so much for having me today. I'm excited to talk about Turning Point and everything we're about to discuss.
Yeah, I'm looking forward to it as well. And we're going to get into the details of substance abuse and what it means for individuals and families. But let's start with the overview. What are the main services or programs at Turning Point Centers?
So to give you a high-level overview, Turning Point Centers has been in business in Sandy, Utah for 12 years. We provide a full range of treatment services for adults 18 and up who are struggling with substance abuse or primary mental health, or in most instances, a combination of both substance abuse and mental health diagnoses. This includes residential services where people are supervised 24 hours a day, day treatment, also known as partial hospitalization, where they come from the hours of 8 a.m. to 3 p.m. We do intensive outpatient, which is more of an 8 to 12-week program, 10 hours a week, typically in the evenings. And we provide sober living, which is obviously, safe, supervised housing. The residents have certain expectations that they need to fulfill in order to be a resident there. We do room searches and, toxicology screenings and all that. And then most exciting is our developing or emerging suite of services that includes long-term aftercare, so case management, individual therapy, medication follow-up appointments with the addiction-focused primary care physician, groups, sober events, things like that.
Because the care does not end, I imagine, just when when an actual program ends.
That's correct. This is a sort of a long-term proposition. You've got to commit to the entirety of the disease, if you will. I mean, it's as they say, once you're a pickle, you can't go back to being a cucumber.
Yeah. I can understand that. It's a wide range of services that you just outlined. Why is there such a range of options?
So, I think there's a lot of people in my space that are touting the idea they provide a very individualized approach to care. But in order to do that, you have to have this complete ecosystem, which is what we refer to it as, in order to meet the very different needs of the people that you cross paths with. So One person may need, 45 days of stabilization in a residential environment to work out some, long-standing childhood trauma, while another individual could be a sort of higher functioning individual that is going to benefit more from staying engaged with their community and really leveraging some of those resources. It just depends on the individual's presentation, their diagnosis, and how severe their symptoms are.
Is that something that sets you apart, would you say? Is that, how do you bring a differentiated approach to treatment? You just mentioned the increase. First of all, we know the increase in the number of people who suffer from substance abuse, but there simultaneously has been an increase in treatment centers. And so it's a crowded environment. It's one where people are often frustrated, scared. They can be depressed. They're looking for help that they might not fully understand themselves. So, what sets you apart, and how do you bring a differentiated approach to treatment?
There's certainly been an increase in the number of facilities providing services in the last 5 to 7 years, and that's by and large one of the very real benefits of the ACA and the parity laws. What sets Turning Point apart is, one, our clinical model. We're not limited to a traditional curriculum of care that's residential treatment, day treatment, IOP. Good luck, keep your fingers crossed. We're committing to being a partner for life with our patients and ensuring that they have those robust, wraparound recovery support services for the long haul. The other thing that clinically differentiates Turning Point centers is our non-12-step approach. We use a very effective combination of evidence-based modalities to really drill down to what the root causes and conditions are. As you can imagine, helping individuals resolve addiction and behavioral health issues is like peeling the onion. It takes time, and you've got to have a lot of different tools in your tool belt.
So, Chris, you just mentioned the non-12-step approach. Give me a little bit more on that. What does that mean, and why did you choose that direction? So,
the one thing I'd like to make very clear is that when we say that we're non-12-step based, that by no means indicates that we're anti-12-step. There's a lot of value from a support perspective in those communities of Alcoholics Anonymous, Narcotics Anonymous. There's a lot of good principles and fellowship there, but we don't integrate them into our treatment program because we believe the majority of people abuse drugs and alcohol as a result of the co-occurring behavioral health symptoms that they present with, the depression, the anxiety, so on and so forth. So we want to use a very scientific, evidence-based approach that has been effectively shown to help heal the biological component of addiction, which is the midbrain or the limbic system that regulates our fight or flight response. So to give you a quick example, if I were to tell you, Chris, hey, I need you to hold your breath for 10 minutes, and you're like, I can't do that. And I say, well, no, you have to hold your breath for 10 minutes. No, you're not going to leave this room until you hold your breath for 10 minutes. And depending on how well conditioned you are, 60, 90 seconds, and then your body kicks in and you breathe. That's your limbic system. Well, the same mechanism is at play with addiction. The person can sort of hold on to some white knuckle sobriety for a period of time until their midbrain becomes so overstimulated and confused that it flips the switch, and they're abusing substances again. And so that's sort of the vicious cycle of relapse, and why we use the clinical modalities that we do to help heal the brain.
How do your patients split then? And I mean, inpatient versus outpatient, and particularly given some of these inputs and some of these factors that you're talking about, are you seeing any trends in that split, or of inpatient versus outpatient, or has it been pretty consistent over, say, the last 3 to 5 years?
Chris, things have been changing over the last 3 to 5 years, and in my opinion, they're changing for the better. It used to be when you said, drug rehab, instantly you thought about some sort of an institutional setting where someone was going to go for a period of 28 days and then, they would get out and everything would be fixed, right? That's obviously not the case. People that show up on our door, they've been struggling 5, 10, 15 years. And as we like to say in the world of recovery, if it's five miles in the woods, it's 5 miles out. We have seen over the last couple of years a trend away from the longer term residential stays where people are supervised 24 hours a day to more community-based outpatient programs that get people functioning more quickly. And I think that's a good thing. One of the unintended casualties of the massive ramp up of capacity in this space over the last 5 to 7 years is the fact that you've got a lot of young people who have been to treatment, 6 times, 8 times, 12 times. And through those experiences, they become institutionalized and they can no longer function outside of a highly structured environment. So the idea is you want them, if needed, to be stabilized at the lowest level of care that they qualify for. And you want to move them into a system that promotes autonomy and independence and self-awareness sooner versus later. And a lot of the evidence that is, really at the forefront of our field is sort of pointing in that direction.
How do families start to understand that? I agree with you. As a layperson, I agree that our collective understanding of substance abuse treatment has certainly grown over the last years. And I think most of us recognize that it's not a situation where, okay, Johnny's got a problem. Johnny goes into treatment. So great, because as soon as Johnny's out of treatment, then it's all over. It's done. He's fixed because that's, he's gone into treatment. I think we do understand that. At the same time, it's a lot, and going in and having to maybe get treatment not only a couple of times, but the ongoing, and when you characterize the the lowest level of care required, that still takes ongoing energy from patients and their families, from individuals and their families. How do folks feel about that?
There's definitely an educational process. I mean, I think a lot of people have heard the term that addiction is a family disease, and what that really means is it affects everybody involved with the person who's, with the substance abuse problem. And you sort of develop this toxic, semi-toxic, dysfunctional family dynamic that impairs everybody's ability to be healthy and well-rounded. So a lot of times, I think the families and I think the people who are struggling themselves, they wait too long to seek help. There's this old mythology, cultural mythology, that an addict has to hit rock bottom before they will change. And the reality is, if we could destigmatize the idea of addiction treatment and bring it more into the mainstream and integrate these best practices into our primary care models and help identify people who are at risk sooner, then, the crises would not get to such a point that the family member would feel like, here, Chris, we've been dealing with this for 10 years and we really just need to get them somewhere safe so that they could, address their underlying issues. So I think a large part of the demand for residential treatment has been driven by the fact that people do not have the access to care or are not aware that they need care earlier in the progression of the disease.
Getting the help early really matters, doesn't it?
Absolutely. Yeah.
Why do people choose Turning Point? What do you hear from patients about what they found or find unique about your approach?
I think the number one reason that people choose Turning Point centers is because the experience they have with the staff from the very first time they pick up the phone. We're in this to help people to be, deeply embedded in the communities that we serve and to be a resource for anyone seeking help. So, for example, everybody on my admission staff knows that each caller, deserves 20 to 30 minutes of their time at a minimum in order to help direct them to the resources that they need. They may not be that particular caller may not be a good candidate for our program, but we know that they need help, and that's the reason they're calling. So it's at the top of our priority list to make sure that when they end that call, they're in a better position to take care of themselves than when they picked up the phone. Regarding our care philosophy and our care model and some of the other things that sort of sets us apart is, we're in network with 9 different payers. We hold more payer contracts than any other facility in the state of Utah. So we make it very affordable to receive high quality care. We're very clear and disciplined in our communications and our processes to ensure that, patients have similar experiences. And most importantly, people know that we're compassionate. People know that we care. People can sense with every interaction with the staff that this is a good place and that they're doing good work. And they're really going to go above and beyond to make sure that my loved one gets the attention they deserve.
And making sure that is felt from the first moment, that really matters. I mean, it's got to start with that first phone pickup, as you mentioned.
Absolutely. By the time people pick up the phone and they start making phone calls, they've been struggling with the situation for quite some time, and they really need some help. And just it's really simple, being compassionate, being available, being conscientious about how we interact with those individuals in that moment, and being absolutely dedicated to the idea that, it's our job to help them. If they're a fit for Turning Point, great. But if they're not, then it's still our duty and obligation to get them the resources they need.
Let's get into, Chris, the clinical excellence and some outcomes measurement. You mentioned, the clinical program a little bit earlier. Do you have a specifically designed clinical excellence plan? What does that look like? What does clinical excellence mean to you?
Yeah, no, great question. So clinical excellence to me is really about being able to codify and memorialize your best practices from a clinical, medical, and operational perspective. And so what we've done is we've taken the evidence. Everyone always likes to point to the evidence in our field. Well, we've actually done the homework to find references to those, ASAM, which is the American Society of Addiction Medicine, or NIDA, which is the National Institute of Drug Abuse, or Shatterproof, which is an emerging organization on the East Coast that's promoting provider guidelines and provider best practices. And we've taken all those material facts and we've sort of put them through the lens of what we've done at Turning Point for the last decade, and we've written a clinical excellence document that's able to inform and guide not only our providers and staff, but the general public, so that they know exactly what they're getting when they come to Turning Point. One example of that is the statistic that only 30-something% of addiction treatment providers make medication-assisted treatment available in this country. And the overwhelming evidence points to the fact that medication-assisted treatment saves lives. But medication-assisted treatment sort of runs afoul of the idea of 100% abstinence. And so, again, there's some cultural mythology in the recovery community that a person can't be on medication and still be sober. Well, here at Turning Point, I'm just plain and simple. I'm a big fan of the idea that you got to keep people alive if you want them to get well. So those are some examples of how our clinical excellence plan.
You've seen the other side of that, obviously.
100%. Yeah, it's unfortunate.
Outcomes measurement is relatively new to behavioral health, Chris. Historically, it wasn't fully on the radar. How do you measure outcomes or success? I mean, you've mentioned some numbers, but how do you measure it, and what does outcomes measurement look like now?
So outcomes measurement is definitely an emerging trend in our space, and a very positive one. Providers need to be accountable to the results that they achieve for their patients, and to the other various stakeholders, including insurance payers and families and community partners. So what we do at Turning Point is we have 2 different stages of outcomes measurement. One, we monitor every patient weekly over about 7 to 10 dimensions, including their depression, their anxiety, their suicidal ideation, any inclination towards engaging in eating disorders, cravings, satisfaction with treatment, conflict with family members, to really try to get an objective overview of their well-being or their progress from week to week. The second stage of our outcomes measurement involves continuing to follow up with the patient at 3 months, 6 months, 9 months, 12 months in an anonymized third-party survey to alleviate any questions about the validity of the data. Furthermore, we support these outcomes initiatives with a very robust and engaging alumni program that not only includes some of the community things you would expect, like support groups and aftercare and some, sober softball and coordinating different things in the community, but more importantly, the actual clinical services required to maintain recovery and, over the long term. So that's being able to meet with a therapist, being able to see a doctor to get your medications refilled, coming in to a group facilitated by a therapist on a periodic basis and being able to process what you're thinking and feeling and experiencing in your, new world of recovery. So for us, outcomes measurement is sort of an overarching term that, one, identifies our accountability to the patients, and two, it's the operational measurements that we use in order to deliver on the promise that we're going to be a partner for life.
And so all of those services that you just described during recovery, after the individual has left, technically left your program, the alumni program, that's all part of what, is part of a turning point relationship and a turning point experience. The experience doesn't end. It doesn't sound like when you walk out the door. Correct.
So, addiction is a chronic, progressive, potentially fatal disease. We saw 77,000 overdose deaths in 2017, despite the fact that prescribing rates decreased by 10% that same year. And in addition to that, what we forget to talk about in the midst of the opioid epidemic is that 88,000 additional American lives were lost to acute alcohol intoxication. That does not include the chronic effects of alcohol. So when you add all that up and you look at our, you look at traditional models of care, you realize that getting people sober is kind of the easy part. It's easy to put together a really beautiful house and some passionate staff and kind of put people through your program and wish them the best. But the hard part is, maintaining that therapeutic alliance and being there for the patient through thick and thin.
Yeah, it's such a theme of what you're talking about that this doesn't, it's not a one and done, any of this, any of the substance abuse recovery. It's not one and done. It's ongoing and helping individuals and families not only understand that, but giving them a framework. Sounds like that's just central. I wanted to follow up, though, as well, the scorecard that you mentioned, those measurements that you do, I think you said weekly. Does that then get shared with the patient, or is that an internal measurement so that you and your teams can really be tracking each individual individually?
Well, it actually happens both ways. I mean, the dimensions that we track are based on surveys submitted by the clients. And so obviously where they're responding to the surveys, they're aware of the answers. But, especially in the early innings, people have a tendency to lack insight towards their behavior or some of the self-sabotage that occurs. So a lot of times those surveys become instrumental in confronting the person in a very compassionate, non-threatening way as to, how they can be their own worst enemy. So we do use them objectively from the perspective of a multi-modality team. And we also use them in our discussions with the patients to sort of test what they're telling us in any given moment.
Is it possible then, do individuals perhaps not even recognize or know or understand that the range of activities? I mean, you talked about, the eating disorders and various things. Do folks necessarily understand how it's all connected? And maybe this gets in a little bit to something called dual diagnosis. So maybe you can talk to me about to what extent do you feel like individuals even have an understanding of the full range of impacts that substance abuse may be having on their lives, but also the connection to various forms of mental illness and dual diagnosis. So I know there's a lot there, but if you can kind of connect that for me and talk to me about, what is dual diagnosis and how do you approach it?
So I think the most important thing to highlight is the fact that substance abuse doesn't happen in a vacuum. Johnny the quarterback doesn't just wake up one day and decide he's going to start smoking Oxycontin and wreck his life. So the vast majority of people with a substance abuse issue experience, the whole range of behavioral health issues. I mentioned trauma earlier. Trauma is probably the most significant co-occurring presentation in our population, in that they've either experienced really terrible things, the kind of things that, we tend to not talk about openly because there's a lot of shame and there's just a lot of, there's a lot of shadow there.
Yeah.
But then there's also, what we call trauma with a little t. And that's the kind of things that, one person may just be very resilient and bounce back from, but another person, due to their disposition or their level of sensitivity, they really sort of metabolize that in a way that's damaging. So we see a lot of people struggling with grief and abandonment. They've lost someone over the years and they've never really been able to get their head wrapped around that. Depression and anxiety are key features for almost every single person that we treat.
Yeah.
Whether that's, sort of an underlying biological cause or just, hey, if you end up in a situation where you're enrolling in a drug treatment program, alcohol treatment program, life's probably not going so great. And then that's going to leave you feeling down and a little bit anxious. So if you think about it, people abuse drugs and alcohol to alleviate the underlying suffering in their mind. I mean, the primary feature is that they're self-medicating, and let's face it, drugs and alcohol are very effective at blunting out those negative emotions and helping people, get the liquid courage or the sort of the social confidence, if you will, to engage. And I think a lot of it's our culture of substance abuse. I mean, people like to get lit up and have a good time and connect. And, in some circles, that's the only way to do it is if you're under the influence. So,
which is why treating the whole person, I assume it's not just the chemical dependency, although that's obviously a big part of it, but it's also the emotional, mental aspect. And it sounds like that's, so much a part of what you address and what you focus on. As I'm listening to you, Chris, it's obvious, and you've mentioned it a bit before, we're not just talking about the individuals themselves. It obviously, these circumstances also affect their families and loved ones, spouses, parents, kids. Is it ever the loved ones who contact you about your services? And those must be very emotional conversations.
70% of the time, it's a loved one that's reaching out on behalf of the person who's struggling. Either because
that's a lot.
Yeah, it's the majority of the time. And usually, this person has just finally realized that they've got to take action immediately. Sort of a longstanding rule of thumb is it takes 7 years for a family to put the pieces of the puzzle together and really understand that their loved one has a problem.
On average, families will deal with this and individuals will deal with this for 7 years before reaching out for help?
Yep, seven years from when the cracks start to appear. And then, Chris, get this, it's another 2 years before they do anything. So now that everybody knows there's a problem, they sort of still skirt around the issue and hope that things will get better. And sometimes they do get a little bit better for a short period of time, but yeah, on average, it takes about a decade for someone to for a family to collect all the information and take action on it.
Which is why it really emphasizes your point. It's almost like there ought to be a campaign of address it early. And I can understand why people don't. I mean, that's hard. Raising, even, let's not even introduce the word confrontation yet. Simply raising the issue, raising the concern. I can imagine those conversations turning angry. They're not comfortable, so people avoid them. We all kind of have a tendency to avoid uncomfortable conversations. Not even thinking about them in terms of confrontation. So I guess two thoughts are going through my mind listening to you. One is, man, the importance of a, act early campaign, and two, just how challenging this can be for family members.
Absolutely, it's super challenging, and to your point, it is human nature to try and avoid conflict to some degree. I think the number one message we try to deliver when we're working with families up front is it's not so much what you say, it's how you say it. It's about approaching the person and really letting them know, hey, we love you. We just don't love the behavior. And we're going to support you because we love you, but we're no longer going to support some of the things that we're doing that are, enabling you to be able to continue this way. I've talked with countless, parents and their adult children who are addicted, and they tell me, well, we paid for another semester of school. We thought that would get them on track, or I don't give them money, but I put, $20 in their gas tank, and, hey, they can't live here, but if things get really bad, we'll let them crash for the night. And, why we're not hardcore advocates for straight tough love. You do have to develop some boundaries and some limits in order for the individual to realize this is real. The other thing I want to say on this is, the idea that the family members are enabling their loved ones is, in my opinion, as stigmatized as addiction itself. Especially if you're a parent. I mean, being, having two boys myself, we're biologically hardwired to protect and provide for our children. Yep. It would be 100% biologically impossible not to do that. So if your kid's struggling and you find yourself, making decisions in the moment and later second guessing yourself, thinking, wow, was that the best thing to do? I just want to give those folks who may be listening some reassurance that that's completely normal.
And how do you provide support for loved ones? So let's say they do, they are able to get, the person who's got the substance abuse issue in their life, they're able to get them into your program. How do you engage with and even provide support for loved ones as, an individual is going through the program?
Up front, it's a lot of coaching. It's a lot of, crucial conversations. Our admissions team sometimes has to get a little personal with someone that they've just met and call attention to behaviors that may or may not be serving their loved one. Of course, we do this from a very, we're there to be their trusted advisor, not tell them what to do, but it's sort of our way of helping them, see truth from fiction. A lot of coaching once they get in. All of our patients receive 3 individual sessions per week at the residential level of care and 2 in PHP. And we try to involve the families as much as possible, either weekly or biweekly, in these small process groups where families can, behind closed doors, really work out their differences and seek to understand what's driving not only the behavior in the individual who's struggling, but the overall dynamic in the family system. There's a great psychoeducation piece to all this too. We have kind of a 6-part series where the families come in weekly for a couple hours and have a very interactive discussion with our clinical team. And we have this family program, this curriculum, if you will, that sort of covers all of the key, aspects of what it means for the family member to support their loved one, what communication should look like, give them good examples of healthy boundaries and the difference between support and enabling. And then also some honest discussion on, hey, how to get some help yourself. If your kid's been struggling for a long time and you're a mom and you're laying awake at night wondering if you're going to get that phone call that your son didn't make it, then you've probably built up some anxiety and maybe some depression as well. So we encourage those folks to reach out and get their own help.
No doubt that's just an unimaginable amount of stress if to lay there every night and spend your days worrying that you don't know when the next shoe may drop and what might occur. It's really kind of the unimaginable. You used the phrase a moment ago, trusted advisor, and it is striking me in listening to you that trust must play an outsized role. I mean, the trust that patients and families put in your hands is immense. I mean, they're truly putting their lives in your hands. That must be very humbling. What does trust mean to you?
So there's a lot of buzzwords in our field, and it seems like every year there's the newest flavor of clinical modality that's going to treat these underlying symptoms, et cetera, et cetera. But at the end of the day, it's the fundamentals that matter, and for us, it's therapeutic alliance. Therapeutic alliance and time and treatment have been studied again and again, and clearly demonstrates that that's what helps people get well. So therapeutic alliance begins the very moment a family member or someone who's an addict themselves picks up the phone and calls in. Trust is built over time. You have to earn trust over time and through consistent behavior. And so that's why it's very important that when people engage with Turning Point, it's a level playing field. And there's got to be trust that when we give them some of that, critical feedback that may be difficult to metabolize, that we're doing it in a good way and that, our intentions are pure. And it is really just also about modeling the trust that needs to be reestablished in these family systems in order for each member to, be on their healing journey. So trust is critical. Therapeutic alliance is critical.
It's got to be a very humbling thing, I would imagine, that the responsibility as well of individuals and families putting these lives in your hands.
It is, Chris. I mean, I'm honored every time that a family picks Turning Point Centers and trusts our staff and trusts the team that we're going to deliver and do a good job. I had my own struggles earlier in life, and you really are in a very vulnerable position, not just as a substance abuser, but as a family, and you're hoping for the best. And so it's extremely important to me as the CEO of this organization that that awesome responsibility is not taken lightly, and that we practice humility and gratitude in being of service to the community.
Let's close out on the point that you just raised, which is you. You know personally the kind of toll substance abuse can take on a person and on a family, as well as the type of work it takes to become and then stay sober, don't you? And does that translate? Tell me about your experience and how does that translate not only into what you do every day, but the meaning and power that your patients get from the fact that you've walked in their shoes?
Thank you for asking. So, quick story. A physician friend of mine got 5 years sober, and I was talking to him. I said, "Hey, congratulations. Kind of sounds like you're out of the woods now." I was probably about 2 or 3 years sober at the time, and he looked at me and he gave me a very sobering fact. He said, "Yeah, even with 5 years abstinence, I'm still statistically more likely to die from substance abuse than any other cause of death." And that was a real wake up call for me, because I was well along the path of recovery, and I kind of thought, oh yeah, once you get to this point, there's a safety net. So that really informs our decision making about the model that we deploy and the fact that we want to be a partner for life, because we realize that, while abstinence is always the ultimate goal, there are, different milestones along the way that include, reducing use, reducing risks and harm from use, reducing the chance of a fatal overdose, being able to improve functioning, being able to have a job, being able to have a relationship, being able to take care of oneself financially. So when you think about that in the context of long-term recovery, you really have to embrace the idea that you do have a chronic disease. It's never going to go away. And even if you have 15 or 20 years sober, that's probably the time when you ought to be most cognizant of it, because it's real easy to become complacent and have the wheels come off. For me, it's about, on a personal note, it's more about having a daily practice, about trying to remain vigilant and self-aware regarding my own thoughts and feelings, and being proactive about self-care, right? We've got to live balanced lives. We've got to monitor that midbrain response, and we got to make sure that we're truly living a life worth staying sober for, and that life, takes priority over anything else that comes into our view.
A life worth staying sober for. That's a note to end on, and that's a key lesson, and really words to live by. Chris, thank you. Thank you for the conversation today, of course, but thank you for the work that you're doing with patients every day and their families.
Thank you, Chris. Yeah, it's an honor. And if anyone wants to reach Turning Point Centers, they can hit us up on the internet, turningpointcenters.com in Sandy, Utah.
Thank you.